Hello and welcome back to lecture. I'm Dr. Varela. Today for week 7, I'll introduce you to nitrous oxide and how it relates to pain and anxiety control. So really quickly, nitrous oxide is known as an inhaled anesthetic, and specifically a gaseous anesthetic. Now, inhaled anesthetics come in two different forms. The first is known as a volatile anesthetic, and these inhaled anesthetics have a low vapor pressure and high boiling point, which makes them exist as a liquid at room temperature and atmospheric pressure. Now, because these volatile anesthetics exist as liquids at room temperature and atmospheric pressure, they have to be vaporized in order to be inhaled. And you can see here on the picture at the right, we have some bottles of volatile anesthetics in liquid form. And just below that, we have the vaporizing equipment, which basically converts those liquids into gases. This is typically what you would see being used by an anesthesiologist in the operating room. The second form of inhaled anesthetics is known as gaseous anesthetics. Now, these exist as gases at room temperature and atmospheric pressure due to their high vapor pressure and low boiling points. Nitrous oxide is one of these gases, which is what makes it readily available for use in dentistry. Now, you'll remember from our discussion about the pharmacology of local anesthetic drugs that we said that it was imperative that local anesthetic drugs were kept from going into the bloodstream so that they didn't go throughout the body. And this helps to decrease the possibility of systemic toxicity. With nitrous oxide, we want things to be a little bit different. We want nitrous oxide's effects to actually reach the central nervous system, and certain qualities of the gas allow this to occur. For example, the uptake, distribution, and elimination of nitrous oxide occur at a much faster rate than the injectable local anesthetics. And this is actually a benefit because we want nitrous oxide to have a relatively quick onset so that the patient can benefit from the experience quickly, and a relatively quick termination so that the patient has a short recovery time. But for the desirable effects to be properly experienced by a patient, the target organ, which in this case is the CNS, has to allow for the concentration to fluctuate rapidly. And there are several factors that actually allow rapid fluctuation of nitrous oxide to occur within the CNS. The first factor is known as inspired concentration. Now, if the concentration of a gas breathed in is high enough, then the uptake into the bloodstream can be sustained for a longer period of time than if the concentration was lower. And that's because the concentration of gas within the alveoli is really what drives the uptake of the gas into the body. And the alveolar concentration can be changed by either changing the concentration of the gas introduced into the lungs, or by changing the volume of the gas that passes through the alveoli. The second factor is a gas's solubility in blood. If a gas is relatively soluble in blood, then its uptake will occur at a higher rate than if it is less soluble. Now, we can measure a gas's solubility in blood compared to the normal gases we breathe, and that measurement is assigned a number. Now, this is known as a gas's partition coefficient. In medicine, it is known as the blood gas coefficient, which can help anesthesiologists determine the solubility of an inhaled anesthetic gas in a patient's blood. The third factor is cardiac output. An increase in cardiac output will increase pulmonary blood flow, which then leads to an increase in the uptake of gas into the circulatory system. The higher the cardiac output, the higher the intake of distribution of a gas. Now, this doesn't necessarily mean that more gas will circulate through the CNS, and that's mainly because blood flow through the CNS is tightly regulated. But it does mean that the gas will be more widely distributed throughout the body, and from a practical standpoint, this means that the patient may experience certain clinical side effects, particularly if the concentration of the gas in the blood is too high. And we'll talk a little bit more about what that looks like later on in the lecture. Digging deeper from an anatomical standpoint, the alveolus is essentially a pocket of air surrounded by a thin membrane that contains capillaries. The gases within the alveoli are separated from the capillaries by about 1 to 2 millimeters of tissue, and this tissue is known as the alveolar epithelium. Now, gases diffuse according to their partial pressures. Oxygen within the alveolus is 103 millimeters of mercury, whereas within the pulmonary capillary it's only 40. Oxygen is therefore forced into the capillary from the alveolus. The same principle applies to nitrous oxide. As the blood becomes saturated with nitrous oxide, usually within 3 to 5 minutes, the rate of diffusion into the circulation decreases. And when nitrous oxide is turned off, the reverse process occurs, thus eliminating the nitrous oxide from the blood. Now, nitrous oxide is relatively insoluble in the blood, which means that it does not combine with any blood elements. Additionally, nitrous oxide is not metabolized in the body at all. So we'll start out our discussion of the pharmacology of nitrous oxide with a comparison of its onset with other routes of administration. Now you notice that the IV and inhalation routes of administration have relatively fast circulation times, which are equal to or less than 20 seconds respectively. This means that the gas will enter the systemic circulation very quickly. It then takes about 2 to 3 minutes for the onset of clinical actions to develop. Now the clinical action peaks for inhalants after about 3 to 5 minutes. Now, you will notice that the depth of sedation is difficult to change with enteral and some parenteral routes. Now, why is that? Well, a change in the level of sedation is highly dependent on a patient's individual response to the drug, which is really deeply rooted in the pharmacokinetics of a drug. And you'll remember that we mentioned that during our initial lectures. Now, with oral, rectal, intramuscular, and intranasal routes of administration, the time that it takes for the drug to be absorbed into the blood and metabolized is really difficult to predict because each patient reacts so differently, which is why one person may feel the clinical effects of a sedative drug like Xanax much quicker than another. Now, this makes it really difficult for us to titrate the levels of the anesthetic drug to a specific clinical action. So it becomes really difficult to change the depth of sedation with enteral and some parenteral routes because we're essentially trying to hit a moving target. IV, on the other hand, gives us directly a direct delivery route of the drug into the bloodstream, which eliminates some of that unknown factor. The drug immediately undergoes biotransformation, and the clinical action of the drug can quickly be observed. Now, this allows us to be able to change the depth of sedation very easily, but only in one direction. We can deepen sedation very easily, but lower the level of sedation is a little more tricky because its elimination is harder to predict between patients. Inhalants, by contrast, are very easy to manipulate because, for the most part, their presence in the body is mediated by constantly introducing them. In other words, the gases are there as long as they're being administered. Once the administration stops, for the most part, the gases are very quickly eliminated from the body. Now, this particular issue is what helps to determine the duration of action. Because gases have a relatively quick uptake and elimination, control over the duration of action is very dependent on the provider. To lengthen the duration of action, you only need to continue to administer the gas for a longer period of time. Conversely, shortening it is accomplished by stopping the administration of the gas. Now, as such, the patient has a very rapid recovery period with inhaled anesthetics, such as nitrous oxide. Because nitrous oxide is not metabolized by the body, once the nitrous is turned off and 100% oxygen is administered to the patient for 5 minutes, the gas is completely eliminated from the body through exhalation. So why do we administer 100% oxygen for 5 minutes? Well, if a patient breathes room air at the conclusion of nitrous oxide sedation, the gas rushes out of the lungs. Unfortunately, more CO2 is removed from the blood than usual, and that lowers the CO2 tension in the blood. Now, as you might know, the presence of CO2 in our blood actually is very important because it triggers the respiratory drive. So removal of CO2 from the blood also removes this drive, thus depressing respiration. The resulting hypoxia produces headache, nausea, and lethargy. Now, this situation is known as diffusion hypoxia or the hangover effect. The situation is prevented by having the patient breathe 100% oxygen for 5 minutes at the end of the procedure. Now, as I mentioned before, nitrous oxide administration is titratable, which means that you can very easily change its levels in the body. This ability to titrate represents the greatest safety feature a technique can possess because it permits the drug administrator virtually absolute control over the actions of the drug. Now, nitrous oxide sedation carries some very important advantages. It can be discharged, the patient can be discharged from the office following a procedure with really no prohibitions on activities. There are really no injections required to administer this sedative or to reverse it. And there are very few side effects if it's administered properly. There's no adverse effects on the liver, the kidneys, the brain, or the cardiovascular or respiratory systems if it's administered properly. And it can be used instead of local anesthesia in certain procedures because it does have some analgesic properties. So there are a few disadvantages to having nitrous oxide. One of the biggest disadvantages is just the cost. It costs a lot of money to set this up in your office, particularly if you're going to plumb it in. It's pretty expensive to get all of the plumbing done for nitrous oxide gases. And then it costs money to keep those gases up. So you're probably going to have a contract with a local medical gas supplier, and they're going to be bringing you canisters every couple of weeks to replace the canisters that you've used up. And it can be pretty expensive, and it can also take up a lot of space in your office. So if you don't have a whole lot of space, that's definitely a disadvantage. Nitrous oxide also is not super potent, so it doesn't necessarily work on everybody. It'll work on some folks, and on other people it just doesn't have very much of an effect. And even on some patients, you can find that it actually makes them even more anxious, particularly the patients that are really they need to have control over everything. They don't like feeling the loss of control that nitrous oxide brings. And so it definitely does not work on everybody. You have to have the cooperation of the patient. So if the patient's not cooperating with it, they're not breathing the way they should be, or even if the patient is breathing mostly through their mouth or not able to breathe through their nose, nitrous oxide is not going to be very effective on those types of patients. You have to have a lot of training with nitrous oxide, particularly if you want to prescribe other medications along with using nitrous oxide. So for example, if you want to prescribe triazolam, which is a benzodiazepine, and then administer nitrous oxide as well, you have to have additional training. This training that you get in dental school is not sufficient for that. So that can be the additional training, and you have to have at least another person that is trained on nitrous oxide administration. So that could be your dental assistant who can help to monitor the patient's status while the nitrous oxide is being administered. And then there's always the possibility of having trace amounts of nitrous oxide that escape from the hood, and that can cause negative effects, particularly in staff members or anybody else who might be pregnant. Now, the whole reason we use nitrous oxide in dentistry is to help address patients' concerns. So for some patients, it's to help address their fear and anxiety about being at the dental office. For some patients, it's to help with some sort of medically compromised condition. And with others, like severe gaggers, it's to help them to get through very simple procedures such as taking impressions or maybe even taking x-rays. And we'll talk a little bit more in these upcoming slides about what conditions really benefit from having nitrous oxide on board as it relates to medically compromised patients. First of all, we talk about cardiovascular disease, and reducing anxiety helps reduce myocardial ischemia by reducing heart rate, force of contractility, and thus the myocardial workload. Now, nitrous oxide is not administered on its own, it's always administered alongside oxygen. So, receiving some percentage of oxygen helps to reduce that oxygen deficit responsible for the onset of chest pains or angina and elevates the pain reaction threshold for the patient. It can also help manage pain during an acute myocardial infarction, not that we would do that in the dental chair. Nitrous oxide has also been found to be the most appropriate technique of sedation for the patient with pre-existing cardiovascular disease. Now, nitrous oxide can be administered safely to patients with asthma because it doesn't irritate the bronchial tree, which is really what triggers the asthma. It's also a really big help for patients whose asthma is stress-induced. If you can lower the stress, you can lower the likelihood of the asthma being triggered. Now, other respiratory conditions such as COPD and chronic nasal obstruction are not good candidates for the use of nitrous oxide. For these patients, there's more of a physical blockage of the alveoli in being able to get enough oxygen into the blood. And so if you replace the oxygen in the remaining alveoli with nitrous oxide, then they'll be receiving even less oxygen. So for these patients, COPD and those who typically have chronic nasal obstruction, this is not a good situation to put them on nitrous oxide. So just remember, don't use nitrous oxide on patients with COPD. With patients that have chronic nasal obstruction, they're probably not going to get a whole lot of use out of it because their nose is closed and we have a nasal hood, and that's how the gas is delivered. And so if their nose is obstructed, then they're not going to be getting any of the gas, so it's not really helping anyways. Now, as you'll notice, a common theme in what we're going to be talking about these next few slides is stress reduction. Now, for patients with compromised medical situations, reducing their stress is essential because stress affects all of these other physiological processes in the body. Now, if these processes go out of whack, the patient's medical stability can be negatively affected. For stroke patients, reducing stress can help reduce blood pressure. Now, stroke patients don't tolerate lower than normal oxygen levels to begin with. And because the administration of oxygen is part of nitrous oxide sedation, these elevated levels of oxygen are actually a major advantage for some of these patients. For those with liver disease, most sedative drugs require biotransformation in the liver, and nitrous oxide doesn't undergo biotransformation within the body and it's exhaled intact. So patients with liver disease, they can benefit from the use of nitrous oxide without any concern. For those who have epilepsy, or seizure disorders, increased anxiety and increased stress can precipitate a lot of these seizure events. So rest assured that nitrous oxide is non-epileptogenic, so it's not going to trigger an epileptic seizure. The other thing is that folks who have epileptic seizures are more sensitive to hypoxia. And so we've been talking over the last couple of slides about how we're also introducing a lot of oxygen along with the nitrous oxide. That oxygen can also help with the patient's making sure that the patient doesn't go hypoxic, right? So you're introducing a little bit more concentrated oxygen than you would otherwise. So that can be a benefit for the patient. But there's really no contraindication for using nitrous oxide on epileptic or seizure patients because a lot of these patients will start to have more seizure activity if they're overly stressed or anxious. And so Nitrous oxide is used to lower the stress and anxiety for patients. Now, a really important group of patients that we need to be careful of are pregnant patients. Now, you should not use nitrous oxide during the first trimester, and that's because nitrous oxide has been shown to produce spontaneous abortion. You also have to be really careful when using nitrous oxide around any pregnant individuals in the office, including yourself if you or your staff are pregnant in your first trimester. And the reason for that is because sometimes the gas can escape from the nasal hood and can contaminate the local air and can cause some of the issues that we're talking about. Now, does this mean that you can't use nitrous oxide on any pregnant women? Now, the answer to that is no. You can use nitrous oxide on pregnant women, but it's always a good idea to remember the following. Use of nitrous oxide in the first trimester is absolutely, positively contraindicated. Use of nitrous oxide during any other trimester should be approved by the patient's OB/GYN. And you should know that nitrous oxide crosses the placental barrier and produces the same degree of CNS depression in the fetus that it does in the mother. Now, we've never really had any reported allergies to nitrous oxide, and so just keep that in mind. For diabetics, there's really no contraindication for the use of nitrous oxide. For the severe gagging patients, it's really effective in eliminating or even minimizing some of that gag reflex, and it might require placing the patient in kind of an upright position while you're administering the nitrous oxide. Its really practical use is for situations where you're going to be doing something short term, so it's not going to take very long, like radiographs will probably take about 15 minutes, 20 minutes at most if you've got a really good assistant. Or if you're going to take impressions don't take very long, usually 2 to 3 minutes. But nitrous oxide can be really effective in helping some of these patients who have severe gag reflex. Now, nitrous oxide use carries with it very few absolute contraindications, but there are several relative contraindications. Now, nitrous oxide can sometimes be bothersome to patients who have a compulsive personality because they don't like feeling that loss of control, and they tend to fight the effects of nitrous oxide, and so it's not particularly effective. In the claustrophobic patients, they don't tolerate the nasal hood very well because it makes everything feel closed in. Also, don't ever use a nasal cannula. And if you don't know what a nasal cannula is just a very thin diameter plastic tube that helps deliver oxygen, typically. And it usually has a couple of prongs that enter the nose so that the patient can breathe oxygen directly. The problem with this type of hose is that it does not have a scavenging mechanism, and really just the scavenging mechanism is where it helps to scavenge or track all of the gas that is liable to escape from the system, so it vacuums it back into the system, and nasal cannulas just are not designed to do that. Also, a relative contraindication for the use of nitrous oxide are children with behavioral problems because it does require a degree of cooperation from the patient. Typically if you have a pediatric patient who's screaming or crying, they're usually doing a lot of screaming, and they're using their mouth to do that, and so they're not really breathing through their nose, and so nitrous oxide is really not going to be particularly effective for them. And lastly, patients with severe personality disorders. Although there's not really any drug interactions per se with any of the psychotropic drugs that patients might be on, a lot of these patients unfortunately have kind of an altered consciousness, and so introducing nitrous oxide to some of these patients can be very disturbing for them because a lot of them already have kind of a tenuous grip on reality, and having that additional loss of control can negatively affect their mental state. Some of the contraindications, some further relative contraindications are those who have respiratory tract infections or other conditions. Particularly for patients who, have a cold or their nose is clogged up and they can't really breathe through their nose anyway, it's not going to be very effective. For patients, and this is not necessarily a relative contraindication, but just a reminder that OSHA standards require that any disposable goods used in the administration of nitrous oxide be disposed of after use on patients that have potentially contagious diseases such as tuberculosis, HIV, and so forth. And the risk there is because a lot of these rubber goods are very porous. They're not very amenable to proper sterilization for use in the next patient, and so the risk of cross-contamination is high. So OSHA requires that those disposables be thrown away. And then, as I mentioned previously, those with COPD are not good candidates at all for the use of nitrous oxide. As a side note, though, make sure that you're always keeping an eye on your patients, your COPD patients, and making sure that they're breathing properly and they're getting plenty of oxygen. I like to have a pulse oximeter on hand to help me monitor their heart rate and also their oxygen saturation. We talked about patients that are pregnant and also staff members or providers that are pregnant as well. So how does nitrous oxide come about? How is it created? Well, it's prepared through the heating of ammonium nitrate crystals, which decompose into nitrous oxide and water. And this is chemically scrubbed to remove the impurities, the acids and alkaline. Nitric oxide is most dangerous. It's the most dangerous impurity because it can combine with hemoglobin and prevent the absorption of oxygen. And then that material is then compressed in a metal cylinder and then delivered for use by medical professionals. Some of the properties of nitrous oxide is that it is non-irritating, sweet smelling, and I would probably argue that the sweet smelling comes from the scented nose hoods. It's a colorless gas, and it's marketed as a liquid that's placed in cylinders under pressure. Now it returns to a gaseous state as it's released from the cylinder. And you might ask yourself, I thought this was a gaseous state at normal temperature, at room temperature and atmospheric pressure. Well, when it's placed in a cylinder, it's not under atmospheric pressure. It's actually placed under a lot of pressure, and so it's forced into a liquid state while it's in the cylinder. It also is the least potent of all anesthetic gases, and it's unable to achieve surgical depth anesthesia unless it's combined with more potent agents. And this is known as the second gas effect. Now, some of the systemic effects of nitrous oxide is, for example, in the central nervous system, you can have a slight depression of sight, hearing, touch, memory, concentration, and pain. You can think about the last time, if you've had nitrous oxide, you can think about the last time that you've had nitrous oxide and how everything kind of, all of your senses started to get kind of closed in, and, the room started getting a little bit darker, and you started having a little bit of tunnel vision. You almost couldn't hear very well, and that's really what that's referring to. So, the central nervous system, there are some slight depressions of those senses, as we've talked about. Postremia, or the vomiting center, is not affected. Cardiovascular system, there's no changes in heart rate or cardiac output. There's slight depression of the myocardial contraction, and there can be some flushing and perspiration. Skeletal muscle, there's no muscle relaxation, so you can't use this as a direct muscle relaxant. And the reproductive system, as I mentioned before, spontaneous abortion and fetal malformation has a slight increase with chronic short-term exposure, and fertility is decreased with long-term exposure. So if you're huffing nitrous oxide gas for a long period of time recreationally, it can definitely affect fertility. Now, chronic exposure to high levels of nitrous oxide is capable of producing sensory neuropathy that can be extremely debilitating, and this is usually seen in people who have purposefully abused the drug. Now, some of the things that I want to make you aware of are some of the steps that you'll be doing when you're administering the nitrous oxide. So I'll review these steps very briefly. Now, first, you want to make sure that you have some sort of monitoring equipment. The monitoring equipment is really going to be important for you to make sure that your patient's respiratory and heart rate and respiratory baseline vitals are within normal limits. So you want to make sure that your monitoring equipment is capable of doing that. So one of the things that I like to use is I like to have either one of these carts that you see on the screen, or I like to have a pulse oximeter and also a blood pressure machine that can quickly take vital signs. And with those two things, I can get a blood pressure, I can also get a heart rate, and then I can also get a oxygen saturation. You want to also make sure that while you're doing these things, you're verbally communicating with the patient, and that you're constantly throughout the procedure, as you're administering the nitrous oxide, you're asking the patient how they're doing. And this really helps with two things. First, it helps you to understand where the patient is, if they're feeling comfortable or if they're not feeling comfortable, if the nitrous oxide is being effective for them or not. But it's also helping you to evaluate the patient's responsiveness and making sure that they are not over-sedated. You want to make sure that you're recording your vital signs periodically during the procedure. And so, if you're administering nitrous oxide, I typically do a vital sign record about every 10 minutes throughout the procedure. And what that is recording the patient's oxygen saturation, their heart rate, and making sure that I record what level or percentage of nitrous oxide they're on, and the volume of gas that's being administered. And then once I'm done with the procedure, I start to put the patient on 100% oxygen and leave them on 100% oxygen for 5 minutes. I don't leave, and I'm constantly monitoring them to make sure that everything's going okay. So on the day of the appointment, you want to request the patient visit the restroom before you get started with the procedure. It can be very disruptive if in the middle of the procedure you have to put the patient on oxygen for 5 minutes and then let them go to the bathroom and then come back and then put them back on nitrous oxide. So make sure that you have them go to the bathroom before you get started. Make sure to review their medical history and record the pre-op vital signs before starting nitrous oxide. Make sure to include blood pressure, heart rate, rhythm and respiratory rate, and so forth. Also, make sure that the patient removes their contact lenses if they're worn, because any gas leaks or any gas that might escape through the nasal hood up into the eyes can dry out the lenses and cause damage to the eye. So the technique for the administration, make sure that you recline the patient in a comfortable position. The only time that you really should be doing an upright position if you're taking impressions or a radiograph. Then you'll want to, if you're using a portable system, you'll want to position that portable system behind the patient and out of the patient's sight. Then you place the nasal hood on the patient's nose and start the gas flow at about 6 liters per minute. And the gas that you will be starting out with is oxygen, so 100% oxygen at 6 liters per minute. Place the nasal hood over the patient's nose and remind them to breathe through their nose. Many people will start to breathe through their mouth, especially if they start getting nervous before this time. They start doing a lot of hyperventilation, and it's typically through the mouth. So make sure that you remind them to breathe through their nose. There's a slip ring on the back of the tubing, and so make sure that once you've placed the nasal hood on the patient's nose that you adjust the slip ring to tighten the hosing onto the headrest of the chair, just to make sure that it is secure in place and the patient is comfortable. Patient should have some freedom of movement even with all this equipment on. They should be able to relatively easily move their head up and down, side to side. If you happen to find that there are some leaks in the nasal hood, between the nasal hood and the patient's skin, then you can use a 2x2 gauze to kind of help block some of those leaks. You do want to put it like it shows in the picture, flat and not rolled up. So don't roll up the gauze and stick it into any gaps, because it will probably move on you and it'll start leaking again. Make sure to adjust the vacuum system, and with our systems here at the school, that's done somewhat automatically for you, but adjust the vacuum system to inhale and exhale comfortably. And that vacuum system is really part of the scavenging system. So you see here on the top, these tubes on the top on both right and left sides deliver the nitrous oxide mixture with oxygen into the nasal hood. And then these larger diameter tubes are vacuum tubes that are connected to your dental chair's vacuum system. And those scavenge the unused gas back into the vacuum system so that the gas doesn't escape into the air in the room. Next step, determine the proper flow rate for the patient. Like I said before, you want to start with about 6 liters of oxygen for an adult, 3 to 4 liters for a smaller adult or pediatric patient. And the patient should be able to take normal breaths without feeling like their breathing is hindered in any way, and making sure that the volume of air is adequate. Now, some patients require large flows, and those are patients that maybe have heart failure or partial nasal obstruction, and you can go up. Make sure that you talk to your attending in the clinic and get some guidance on them on how high to go, but typically we want to leave it at about 6 liters per minute. Ask the patient if you can breathe normally, so communication is going to be really important. And if they can't breathe normally, then you can increase the volume by 1 liter per minute. You might need a higher flow rate at the beginning, especially if it's the patient's first time, and then you can drop back down to a regular flow rate. Now there's a reservoir bag attached to these systems. Not only is it attached to the digital system that we use here at the school, but it's also attached to some of these portable systems. And the reservoir bag is really just a big green bladder, a rubber bladder that kind of, you fill it up with air. And you want to make sure that when you fill it up with air, that you watch the movement of the reservoir bag, because as the patient breathes, the reservoir bag should expand and contract along with the patient's breathing. And if it's not doing that, then you have a blockage somewhere and you have to find where that blockage is. Now, one of the things that's really important to understand about these systems, regardless of whether they're digital or analog, is that these systems have this reservoir bag in an effort to mix the gases. So it's going to mix the oxygen with the nitrous oxide. And so presumably once you've started administering nitrous oxide, The gas that is present inside of that reservoir bag is a mixture of oxygen and nitrous oxide. So that's very important to understand. Now, there are two different methods of administration, and they're named constant liter flow and constant oxygen flow. And you can read what that says on the screen. This really doesn't necessarily apply to our systems here because all of this is done automatically for you in our digital systems, and so this really kind of refers to these portable systems that are a little bit more manual in um, their approach to administering this gas. Now, all throughout your procedures, you want to make sure that you're constantly observing the patient. Um, the term that I like to use is situational awareness. You have to be aware of absolutely everything that's going on while you're administering nitrous oxide. You want to make sure that you are aware of the patient's vital signs, and that's done every few minutes and recorded. You want to make sure that you are aware of the patient's responsiveness, whether they're responsive to any questions that you might ask them. I always, every few minutes, I always ask the patient, "How are we doing?" And then they give me a thumbs up, or if they don't respond, then I probe a little bit further. Sometimes people will fall asleep when they're doing this because they're so relaxed, but you want to make sure either way that they're doing well. Even if they're falling asleep because they're relaxed, I want to make sure that I'm in there talking to them and making sure that they're okay, because that's really one of the things that you will use as an indicator of the patient's status while you're administering nitrous oxide, is whether the patient is awake, alert, and aware. So what I typically do when I start giving nitrous oxide to a patient is I start at around 20% nitrous oxide and then ask them how they're feeling. Are they feeling like the nitrous oxide is kicking in? And typically, if you've got an average-sized adult patient, they typically don't respond a whole lot to about 20%, so I start bumping it up to 25 or 30 and then ask them how they're doing, and that usually does the trick. The other thing that you want to do is make sure that the patient's legs are uncrossed, and patients will rarely move when sedated, and so there's a problem with lack of circulation, which could cause some paresthesia or hyperesthesia for some patients. And this really just kind of goes back to the same issue of talking to your patient, communicating with them constantly. And then once you've started with the nitrous oxide, you will continue to observe the patient and titrate as needed. So what that means is basically that you're going to make sure that the patient is doing well. If the nitrous oxide is not working, then if it's appropriate, then you might bump it up a little bit. If the patient is starting to say that they're feeling lightheaded, which is usually the first effect when you start administering nitrous oxide. Some people say that they feel dizzy or they might feel lightheaded. You ask them if they feel really uncomfortable and just really communicate with the patient so that you know that this is a really dynamic situation, and so you need to be aware of whether these symptoms that are presenting are acceptable for the patient or not. Don't just assume that the patient is okay with it. So constantly communicate. But if they do feel a little bit of lightheadedness, and this is mild lightheadedness or maybe a little bit of dizziness, this is normal and it will pass usually as you increase the nitrous oxide. But if it becomes uncomfortable for the patient, don't force them to go any higher. Stop what you're doing. Ask the patient if they'd like for you to stop the administration of nitrous oxide, and then act accordingly. The patient might report feeling a little bit of tingling or paresthesia of the arms, legs, or mouth. And this symptom develops at a level that's really kind of still too low for the patient to start feeling the benefits of nitrous oxide. And then patients might also feel like a warmth or a floating heaviness. And this is where you start getting into the ideal levels of nitrous oxide sedation because that's indicating that the patient is feeling very relaxed and they're feeling comfortable. Now, this slide, I want you to know this slide inside out because you will be asked questions on identifying whether a patient is in early to ideal sedation, if they're in heavier sedation or slight over sedation, or if they are in slow sedation, or if they are in over sedation, according to the symptoms and signs that would be presented to you. And then again, observe the patient. A lot of patients might start to feel uncomfortable with nitrous oxide, so decrease the nitrous oxide by 5% at a time, and that might help them. Really, this all comes down to situational awareness. Make sure that the patient is comfortable. The whole reason for using nitrous oxide is to help, remember, to help address those things that we talked about. Address the patient's fear and anxiety, to address the severe gagging, or for medically compromised patients for some of their situations. And if this is doing more harm than good, if it's making the patient more uncomfortable and more nervous, then it's not really it's not being a benefit to the patient. So be aware and talk to your patient constantly. If you're dealing with a patient who's never been sedated with nitrous oxide and this is their first time using it, it might be a little bit more difficult to gauge whether it's being effective for them or not. And so this again goes back to making sure that constant communication with the patient is really, really key. And as the sedation increases, the patient's responses become a little bit slower. So there might be a little bit of lag time between questions and answers. So if you ask them a question, it might take a minute or a second or two for the patient to answer. And it might be a good indication that you're right around your ideal level of sedation. And then once you've got the patient in with nitrous oxide, then you can start doing your dental treatment. A lot of times, once you start doing your dental treatment, you'll be able to have a really good indication of whether or not the nitrous oxide is enough for the patient. A lot of patients will give you a thumbs up, and that's usually the patient that's happy because it's working and they're not feeling nervous or afraid of all the sights and sounds and smells that are associated with dentistry. And it's not unusual for patients to move around while they're doing this, while you're doing a procedure, because remember, you're doing something traumatic. Whether you're doing a filling or doing an extraction, it's still kind of a traumatic experience, and it's not uncommon to have people move around. And that doesn't mean that the nitrous oxide isn't working. It just means that the patient's a little bit more a little bit more antsy and moving around. But if it is disruptive or significant, stop and evaluate whether or not an increase in the percentage of nitrous oxide is appropriate. Typically when you do that, it will help to eliminate the problem. Now, once you have established pain control through the use of local anesthetics, the procedure usually goes on without a hitch, and so that's really important because that means that your nitrous oxide administration is working. Make sure that the inhalation unit is being monitored constantly during the procedure. I usually have my assistant either put an alarm or a timer for about every 10 minutes so that we are constantly monitoring the patient's vital signs, and also it forces us to look at the machinery so that we can see if it's working properly. I typically am looking at it anyway because I'm looking at that green reservoir bag to make sure that it's completely inflated, because if it's not inflated and it's flat and it's devoid of any of the mixed gases, then the patient is not getting nitrous oxide. And so you have to kind of keep your eye on that constantly. Now, the patient should be able to respond to questions that you pose to them, and a lack of response indicates that the treatment should be halted or even terminated immediately, and make sure to reevaluate what's going on. Usually decreasing nitrous oxide by 5 to 10% quickly brings a response. So just make sure that you're constantly observing and communicating with the patient and observing the inhalation unit during the procedure. Now, once you've done your dental work and you've completed the dental procedure, you will want to slowly terminate the flow of nitrous oxide and increase the level of oxygen to 100% and leave the patient on 100% oxygen for about 3 to 5 minutes. I will say that it's 5 minutes every single time. And also know that this automatically does it for you on the system that we have. The digital systems will automatically increase the proportion of oxygen as you decrease the proportion of nitrous oxide. And so, if you have, let's say you have the patient on 30% nitrous oxide, well, the patient's receiving 7% of or 70% of nitrous oxide at a volume of 6 liters per minute. And so if you are decreasing it to 0, then that will automatically increase the percentage of oxygen to the patient to 100%, and it does all that mixture for you. Now, what do you do if a patient is still feeling a little off, still feeling like they're under the influence of nitrous oxide after 5 minutes? Well, you just keep them on the oxygen a little bit longer and constantly communicate with the patient and try to evaluate what the symptoms are that they are experiencing. A lot of times people maybe are not breathing as deeply or as rapidly as they should, while they're on the oxygen. So sometimes the patients will have just very shallow breathing. And so it's really important to make sure that you ask the patient to breathe deeply during that 3 to 5 minute period of time. And it takes a little bit of time for the patients, especially the first time patients, to get used to nitrous oxide. And they may feel a little bit off during this first time. And so just make sure that you're constantly talking to the patient and communicating with them and evaluating their vitals and also how they're feeling. Make sure that when you discharge the patient, you are able to evaluate that the patient is awake, alert, and aware, and the patient is able to resume their normal activities without any prohibition. Now, for this reason, the dentist must be absolutely certain that recovery is complete before discharging the patient. Okay, it's really important that you don't let that patient leave until they're completely back to normal. If the patient is still, after 5 minutes, if the patient is still feeling a little lightheaded or dizzy, don't discharge them. Don't throw them out of the chair. Keep them there in the chair, have them breathe oxygen, and then when the patient is comfortable and able to leave on their own, then you can discharge them. But it's really important to be a responsible user of nitrous oxide and make sure that that you're monitoring this patient. It's all about the patient. It has nothing to do with the on and off switch that you've thrown for the nitrous oxide. It is all about making sure that that patient is awake, alert, and aware, and that you are responsibly releasing that patient to go about their day. And one of the best things that you can do is making sure that you ask questions and that the patient is giving you purposeful responses. So it's really important to make sure that the patient is able to answer your questions purposefully, and maybe even doing something like the trigger test, which basically asks the patient to coordinate between listening to a command and actually doing it physically. And basically, the trigger test is having the patient touch the tip of their nose with their little finger. And it's really useful in medical legal documentation to say that the patient passed this trigger test and was able to touch the tip of their nose with their little finger. And again, there's the medical legal responsibility, but there's just the human part of it all in making sure that these patients are being released safe and sound. And finally, making sure that you have good hygiene on your equipment and disinfecting the parts that can be disinfected, and also cleaning and disposing of any parts that are disposable and need to be disposed of, and then sterilizing the parts that can be sterilized. So really quickly, the nasal hoods here at the dental school are really thrown away because they're one-use nasal hoods. Very little is sterilized except for the tubing, and the tubing a lot of times will be stored in glutaraldehyde for 10 hours and then rinse with warm tap water for about an hour. These 15 steps are covered in a very short video that I posted on your module for this week, and the module basically goes over in video format in a YouTube video how this all looks put together. These 15 steps are, it's on paper it's a really long process, but in practicality it's really not very long at all. So I think that the video that I posted is about 3 minutes or less, or maybe a tiny bit more, but it's around 3 minutes long, and it goes through all these 15 steps, and I show you specifically the system that we use down in the clinic, and it will put a lot of these last few slides into context for you. I hope that this has been a very valuable lecture for you. I want to thank you for being with me today. Please don't forget to share one thing that you learned from this lecture in this week's module, and also don't forget to take the quiz. Thank you very much.